Welcome to Chapter 28, Helpful Hints for the Circulatory System. So this is one long chapter, a really long chapter. So just like with the pregnancy and childbirth chapter, I do want you to read through the entire chapter to get a good lay of the land. However, please note that on Blackboard, you do have a limited number of exercises to complete. If you are feeling confident with the exercises and the items or concepts reviewed in this video, this lecture video, you will be okay for a quiz or an exam. Please just know, in the real world, you would be accumulating a large amount of experience and receiving a large amount of training before being asked to code for complex circulatory records. So for purposes of this beginning course, we just want to sort of dip our toes in a little bit and try to narrow the focus a bit for you. Before we begin, remember, as usual, to keep a close eye out for instructional notes, as they are pretty numerous for this particular body system when it comes to coding. Let's start our review with the term angina pectoris. This is basically just a symptom, so keep in mind your signs and symptoms coding in this chapter. This is a symptom of an underlying heart disease. So angina pectoris just means that there is severe chest pain or maybe even a feeling of pressure that can radiate down through the shoulders and neck and even the arms. This is caused by a narrowing or a blockage in the arteries that in turn results in a reduced blood supply and reduced oxygen to the heart. Often in medical documentation, you will see the terms stable angina and unstable angina. So let's do a quick review to understand the difference, as it really is important to your coding. So for stable angina, this chest pain has a typical pattern to it. It usually happens after strenuous exercise, exposure to extreme cold, perhaps after smoking or eating a big meal, or even just having a high level of stress for a particular thing going on in your life. So again, there's a typical pattern to it. Usually the pain will go away with rest after that triggering event, or if you were given a nitroglycerin tablet, which is basically just medication used to relax and dilate the blood vessels. So that stable angina will go away with that nitroglycerin or after the triggering event. Unstable angina, on the other hand, is very unexpected. It does not have a typical pattern. It is usually a warning sign that a heart attack may be imminent. It usually happens at rest or with light activity, so nothing strenuous as we were doing over here with strenuous exercise. You're basically just sitting there or doing something light like washing the dishes. The pain will remain after an extended period of rest, or if the patient is again given a nitroglycerin tablet, that chest pain will still be present. So that's the difference between stable and unstable angina. It's important to note that unstable angina may not always be documented as unstable. So when you're working in a medical record, some good clue words to keep an eye out for are accelerated angina, crescendo angina, de novo effect angina, or worsening effort angina. So if you see any of these words documented within the record, just know that they are actually referring to unstable angina. Now, unstable angina may be used as a principal diagnosis only if no other diagnosis is documented. So we're sticking to that guideline that we've been following about signs and symptoms all semester. So, for example, if they make a final decision about a certain heart condition, that would certainly be listed as a principal diagnosis. But if nothing else is going on and they have no other related diagnosis, you may use unstable angina as the principal diagnosis. Let's talk about some coding considerations for myocardial infarctions. This is just a nice way of saying a heart attack. Now, before we begin this discussion, I do want to draw your attention. I always have students that want to call this term an infraction. Please note that it is not infraction, it is infarction. An infraction is when you break a rule, right? At school, you break a rule, you cheated or something, you have an infraction. An infarction or an infarct is basically the noun, the infarct, is just an area of damage or death of a tissue. And in this case, it's that damage or death of the heart muscle. So, a myocardial infarction. So, I'm off my soapbox now. The one thing I want you to remember for myocardial infarctions, you need to keep in your head this time frame of 4 weeks. Encounters for acute myocardial infarctions, or any that happen within a 4-week time period, are coded to category I-21. If a patient needs continued care for an AMI, code from this category I-21. This may be used for up to 4 weeks or 28 days from that onset of the original myocardial infarction. Encounters for care for a myocardial infarction that are after that initial 4-week time period. If you're still needing continued care after that 4-week time period, you will use the appropriate aftercare code. And this can be found in your CM index. We've used it a couple times this semester, but that main term of aftercare. So you will not be using a code from I-21 after that 4 weeks. Please go to aftercare as your main term. If a patient suffers an AMI and within that 4-week time period, the patient suffers a new AMI, so again, within that 4 weeks of the original, we will code that second AMI to subsequent myocardial infarction. So we would have our original myocardial infarction coded to the category I-21. Then we would pull in that second MI code that happened within that same 4-week time frame to the category of I-22 for subsequent AMI. Looking at a couple of examples here. So our first one, a patient is admitted for an acute myocardial infarction and has another AMI while still in the hospital for the first AMI. So they're within that 4-week period of the original. So we would code as our primary a code from category I-21 for that original AMI, and then we would pull in a second code, whichever one would be most appropriate, from category I-22 for the subsequent AMI. However, if the patient is admitted for an AMI, then is discharged, so up here we were still in the hospital when we had that second AMI. Here the patient is discharged. At home, the patient suffers another AMI within that 4 weeks of the initial AMI, so we have a subsequent, but this time we're being readmitted. So this time, the code from category I-22 for subsequent AMI would be sequenced first before the code for the original AMI I-21. As a reminder, this 4-week consideration for AMIs is referenced for you in the circulatory system guidelines. So we've been talking about this a few times now this semester about referencing those chapter-specific coding guidelines when needed. So take a minute this week, check it out, go to that circulatory system section. It's just a page or two in the guidelines and read through there. Become familiar with it. Remember that you never need to memorize these guidelines. They're always with you in the code book for reference, but it is a good idea to have a nice frame of mind to realize what is actually included in those guidelines. So please take a look. Two other terms that we often see in AMI documentation are STEMI and non-STEMI. So what's the difference? A STEMI AMI is usually caused by a long period of blocked blood supply. This results in full thickness damage to the heart muscle, causing part of that muscle to die. But a non-STEMI, that does not have a long period. It has a short period of blockage. So there may be a clot, say in the coronary artery, but it breaks up on its own, so there was just an incomplete blockage for a short period of time. In this case, the damage is usually minimal and the function of the heart stays normal. So you may hear something mentioned about Q waves. If the patient has an EKG or ECG, electrocardiogram, for a STEMI AMI, those Q waves will be present, and on the non-STEMI, those Q waves will not be present. So this is basically just for reference sake, so you have something to refer back to in your mind. Usually in the documentation this chapter, it will be specific and specifically say STEMI or non-STEMI, but at least you now know the difference once you get into that medical setting. Now let's touch base about heart failure, or sometimes CHF, congestive heart failure. This is when the heart muscle is weakened and cannot pump enough blood to accommodate the body's need for oxygen and blood, so it's possible to be treated for the signs and symptoms of heart failure and live for years with the condition. It can be with you for a long time. When you're coding for heart failure, you usually see it's documented to one of two types, either systolic heart failure or diastolic heart failure. Systolic, this is when the ability of the heart to contract decreases, and diastolic heart failure is when there's a problem relaxing between the contractions, and this in turn does not allow enough blood to enter into the ventricles. So keep these definitions in mind when coding. Now let's discuss hypertension for a minute. As I mentioned earlier, take a few minutes to review the circulatory system guidelines this week. You will find some great information, especially in regard to hypertension. But let's talk about a few types that you may see documented. So the first one is essential or primary hypertension. This is high blood pressure that does not have a known cause. It tends to develop gradually over many years. In documentation, you will see some clue words that basically equate to essential hypertension, such as accelerated hypertension, benign, malignant hypertension, of course, essential primary, systemic, or even idiopathic hypertension, thinking back to medical terminology, idiopathic, pertaining to self-disease. So it's a disease of unknown cause. All of these clue words will lead you to code I-10 for that essential primary hypertension. Secondary hypertension is a result of some other disease or an underlying condition. And in this case, two codes are always required. And this is actually mentioned again in the guidelines, so I'll emphasize that again. Take a look at the circulatory system guidelines. But if you do have a diagnosis of secondary hypertension, you need to code again with 2. So let's look at an example. Hypertension due to systemic lupus. We would pull in the code for the lupus in addition to the code for the secondary hypertension. Another type of hypertension that you may see documented is transient hypertension. This just means that the blood pressure, it goes pretty high temporarily, but then later it returns to normal. So if hypertension is documented as transient only, with no other mention of essential hypertension or any other type of hypertension, but just simply transient hypertension, we will code to elevated blood pressure without diagnosis of hypertension. So instead of coding to that main term of hypertension, we will be going to the main term of elevated with the subterm blood pressure, which leads us to code R03.0. So something else to keep in mind when you see that transient documentation. Now let's take a quick look at some PCS root operation terms for some common circulatory system procedures. Let's try to connect these procedures with the correct root operation term. So let's begin with a simple, non-invasive diagnostic cardiac catheterization. This procedure is used to help diagnose cardiovascular conditions where a catheter or a tube is inserted usually in an artery or a vein in the groin, sometimes in the arm or the neck, and then it's thread up through the vessel to the heart. And when they get there, they can do intracardiac readings within the heart, such as pressures or tracings. They can take measurements of cardiac output. So these diagnostic catheterizations are coded to the root operation of measurement. They're taking measurements within the heart. Often in this chapter, you will see documentation about implantable devices. So the physician is implanting within the body a device such as a defibrillator, a cardioverter, perhaps a pacemaker. And know that when the physician is inserting one of these devices, it is coded to the root operation term of insertion. If there is a procedure where they are taking out that device, then it will be coded to the root operation of removal. Now, this is a good place to remind everyone. A few of you are still struggling with this concept and understanding the importance of those root operation definitions. But it's important to remember that physicians don't always speak the same language as a coder. So if the physician says, perhaps total removal of the gallbladder, remember that we are only coding that to a resection. Even though the physician may have documented removal, we need to code to a resection. That definition of resection is taking out all of a body part. That root operation removal for coders only refers to devices. So a physician says, I'm removing a body part, you need to decide, is it an excision, a portion of a body part, or a resection, all of a body part? So again, even if they document removal, we know we can't code that body part to removal because we know in our coder speak that removal would only be appropriate when removing devices from the body. PTCA procedures, percutaneous, transluminal, coronary angioplasty. This is a minimally invasive procedure to open up blocked coronary arteries. It involves the insertion of I guess picture a tiny little balloon, a little balloon that is placed into the vessel and then it's inflated to open up or widen the artery. And this process of inflating the balloon is causing the artery to open up or dilate. So PTCA procedures are coded to the root operation of dilation. Coronary artery bypass graft. These procedures are often called a cabbage procedure. This is for the treatment of coronary artery disease. It grafts a piece of healthy blood vessel taken from somewhere else in the patient's body or from another source, and then attached to bypass or go around the blocked portion of the coronary artery. So this one's kind of a simple one, just as it sounds. A cabbage procedure would be coded to that root operation of bypass. Atherectomy procedures and thrombectomy procedures are coded to the root operation term of extirpation. So remember that we are removing solid matter from a body part. We've talked about this root operation term a few times this semester, but remember that extirpation is removing solid matter from a body part. And when you look at the definition of extirpation in your appendix, you'll be reminded that solid matter could be anything from perhaps a fish bone cutting into your throat, but it can also mean an abnormal biological byproduct of the body. So in this case, the plaque, the atherectomy, we're removing the plaque from the arteries, and the thrombectomy, we're removing a blood clot. Both of these are considered solid matter as they are abnormal biological byproducts. So again, these procedures would be coded to the root operation of extirpation. Let's take a quick look and walk through one procedural statement together for this chapter. So here we have an aortocoronary bypass, left diagonal and left circumflex arteries with greater saphenous vein graft open. And in addition to that bypass procedure, we also have cardiopulmonary bypass, extracorporeal, cardiac. So let's stop here and take care of this section first. So here we're doing a bypass from the aorta to the coronary arteries, two of them here, left diagonal and left circumflex. So we'll start with our main term in the PCS code book with our root operation of bypass, artery, coronary, and then two sites. We're bypassing from the aorta to these two sites, the left diagonal and left circumflex arteries. So that'll lead us to the fourth character of 1, where we're bypassing 2. The fifth character will be 0 for the open approach. 9, this pulls in the autologous vein tissue because they're telling us they are replacing this graft that they took from the greater saphenous vein, so it came from the same person, so it's autologous. And then we pull in the last character of aorta, W aorta, when you look at the table, which is from. Now, I want you to pay attention here. We haven't talked about this too much, but in the CM codebook for diagnoses, we've been really talking about those guidelines. Well, please remember that the PCS codebook has some guidelines too, okay? They're not as robust as the ones in CM, but there are a few in there, so you should take the time to check it out a little bit. But here's a picture from your PCS codebook, the guidelines in the beginning of your codebook, where it talks about bypass procedures. So normally, we're here. Bypass procedures are coded by identifying the body part bypassed from and the body part bypassed to. The fourth character body part specifies the body part bypassed from, but here we did to. And the qualifier specifies the body part bypassed to, but here we did from. Why? Well, they have a special guideline for coronary artery bypass procedures. These are coded differently than other bypass procedures described in the previous guideline. Rather than identifying the body part bypassed from, the body part, character 4, identifies the number of coronary arteries bypassed to. So remember, we have these two arteries bypassed to. And the qualifier specifies the vessel bypassed from, the aorta, when you look at the table. So just another thing to have on your radar screen when you get stuck coding for PCS procedures, please know that they also have guidelines, just like the CM code book. So moving on here, since we replaced this section of artery with an autologous transplant, right, from the patient, from the same patient, we took part of the right greater saphenous vein. We need to pull in, as part of this procedure statement, not only the bypass, but the harvesting of that greater saphenous vein portion. So here we would go to excision, greater saphenous right, which leads us to this code. And then we still have this last sentence here, cardiopulmonary bypass, extracorporeal cardiac. So this means, we've talked about this a few times, extracorporeal, outside of the body. So basically they're telling you that they're hooking this patient up to the heart-lung machine. They're saying, hey, we had this machine outside of the body taking over the function of the heart and the lungs while we were performing this artery bypass procedure. So we need to remember the definition of the root operation of performance. And this means completely taking over a physiological function by extracorporeal means, taking over functions of the body outside of the body. So this is where we're going to find our main term performance, subterm cardiac, continuous output, and it leads us to code 5A1221Z. Good luck with this long chapter this week, and remember to feel free to post any questions to that coding roundtable and check it out often, even if you aren't posting questions. Happy coding!